Bismillahirrahmanirrahim. So now we are going to start with the molluscum contagiosum. Molluscum contagiosum is an umbilicated papules caused by the pox virus. So here you can see uh, the umbilicated papules which are present over here. Papules are raised lesions, and papules are not vesicle. So they are not fluid filled, and they are raised lesions. So umbilicated papules which are caused by the pox virus, while frequently seen in the children, it may be sexually transmitted in adults. In children, they are frequently seen, and in the adults, if they are seen in the adults, so they may be sexually transmitted. And affected keratinocytes show cytoplasmic inclusion molluscum bodies. So here you can see the molluscum bodies inside the cytoplasm of these cells, I guess. Over here, these are the molluscum bodies, like these things, and they are caused by the molluscum contagiosum virus. The pox virus contained a variety of viruses, for example, the smallpox virus or maybe the cowpox virus, and the molluscum contagiosum virus is one of the viruses belonging to the pox viridae family. Then moving forward to the varicella zoster virus. Varicella zoster causes a lot of vesicles, so causes varicella chickenpox and zoster shingles. So varicella zoster is the varicella virus is going to cause chickenpox in children, and zoster is shingles virus. That is not shingles virus. Shingles is the basically reactivated form of the herpes zoster. Varicella presents with multiple crops of lesions in the various stages from vesicles to crusts, and zoster is a reactivation of the virus in the dermatomal distribution unless it is disseminated. If the person is not immunocompromised so much that there is dissemination, there will be dermatomal distribution of the virus reactivation. What is hairy leukoplakia? Irregular white painless plaques can on the lateral side of the tongue. So here you can see that on the lateral side of the tongue, you may get irregular white and painless plaques, cannot be scraped off, contrast with the thrush which is scrapable, and leukoplakia which is precancerous. Okay, so hairy leukoplakia is a benign condition. Okay, leukoplakia. Okay, so you have to contrast this with the thrush which is scrapable, and leukoplakia, hairy leukoplakia. Okay, maybe there is a difference of hairy leukoplakia versus leukoplakia alone, but leukoplakia is precancerous. Epstein-Barr virus mediated. So hairy leukoplakia is caused by the Epstein-Barr virus. Often occurs in HIV positive patients, organ transplant recipients. The person basically who are immunocompromised, they can develop hairy leukoplakia. Why is it called hairy? Because they seem to be the white hair development of the tongue. If you see it over here, hairy leukoplakia. So in the hairy leukoplakia, you can see it as if hair are growing on the side of the tongue. So leukoplakia or hairy leukoplakia, pre-malignant. So leukoplakia is defined as white patch of plaque that cannot be scraped off or ascribed to any other clinical condition. Leukoplakia has long been known to be a precancerous lesion for oral squamous cell carcinoma. So yes, hairy leukoplakia is there written? Okay, give me a second. Despite this title, oral hairy leukoplakia is not regarded as pre-malignant, as it's unlikely to give. Okay. So the oral hairy leukoplakia is it's pre-malignant. It's not pre-malignant. This condition is not going to cause cancer, while the leukoplakia alone and the thrush, the leukoplakia can cause cancer, so that is precancerous, and thrush can be scrapped off. So you have to differentiate the oral hairy leukoplakia caused by Epstein-Barr virus from the thrush that is caused by the candida, and leukoplakia that is a lesion of the tongue or some other area. Moving forward, blistering skin lesions. So there are two very important blistering skin lesions. First one is pemphigus vulgaris, and second one is bullous pemphigoid. So the desmosomes, they are present normally in the stratum spinosum. Yeah, they are found in the stratum spinosum, and the hemidesmosomes, they are present in the stratum basale, because hemidesmosomes are going to connect the stratum basale to the basement membrane. So that is why they are present only in the stratum basale, while the desmosomes, they are present in the stratum basale as well as stratum spinosum. Then we have the basement membrane. So in the pemphigus vulgaris, we have antibodies directed against the desmosomes, so they will peel or they will pull the stratum spinosum upwards and detach it from the stratum basale. So there will be a fluid or accumulation of stuff between these two layers, stratum spinosum above and stratum basale below. That is pemphigus vulgaris. And in the case of bullous pemphigoid, the IgG antibodies are directed against the hemidesmosomes. So the stratum basale is lifted off from the basement membrane, and the fluid accumulation is below the stratum basale, and so basically the epidermis is differentiated or separated from the dermis that is lying below that. This is the condition that we find in the bullous pemphigoid. Remember this, and now we'll talk about each condition individually. Pemphigus vulgaris, autosomal destruction of the desmosomes between the keratinocytes. IgG antibodies against the desmoglein, component of the desmosomes which connect the keratinocyte in the stratum spinosum. It is a type 2 hypersensitivity reaction because antibodies are circulating freely and they are going to target the antigens which are residing comfortably in their places. They are not moving. Antigens will not be moving in the type 2 hypersensitivity reaction. It is the antibodies which are made against body's own antigens, and those antigens are targeted by the freely mobile antibodies. In the case of type 3 hypersensitivity, both antigens and antibody are mobile, and in the case of type 1 hypersensitivity, the antibodies are residing comfortably on the mast cell or maybe the eosinophils, and the antigens approach the antibodies. So there are the teeny differences. But remember, the in type 2 hypersensitivity reaction, the antigens are on their place. For example, in our case, the desmosomes are on their place, and the antibodies which are formed in the serum, they will come and join these antigens, and that is a type 2 hypersensitivity reaction. The pemphigus vulgaris presents as skin and oral mucosa, flaccid intraepidermal bullae. As you can see in this picture, these are bullae which are flaccid intraepidermal bullae. Acantholysis, separation of the stratum spinosum keratinocytes normally connected by the desmosome, result in suprabasal blisters. So acantholysis means separation of the stratum spinosum keratinocytes from the stratum basale, normally connected to the desmosomes, normally connected by desmosomes, result in suprabasal blisters, which means the stratum basale is intact and the blisters are formed above the stratum basale. That is why they are called as suprabasal blisters. Basal layer cells remain attached to the basement membrane via hemidesmosomes. That is why it is going to form the tombstone appearance. So tombstone is, on the graves you may see a stone like that, tombstone. So the basement membrane, the stratum basale is attached to the basement membrane, like all the way here, and this forms, a vesicle bulla is formed in such a way that the fluid is collected between the stratum basale and stratum spinosum. So a tombstone appearance is acquired by these layers. Thin-walled flaccid bullae rupture easily, that is Nikolsky sign, that we also saw in the scalded skin syndrome caused by the Staphylococcus aureus, leading to shallow erosions with the dried crust. The bullae spread laterally when pressure is applied on top, that is called as Asbo-Hansen sign. The bullae spread laterally. Okay, so Asbo-Hansen sign means that if you apply the pressure on the bullae, they will start spreading laterally. Okay, that is called Asbo-Hansen sign. Immunofluorescence highlights IgG surrounding keratinocyte in a fishnet pattern. So the option B, they are showing a fishnet pattern. Yeah, here we can see the fishnet pattern over here. Also involve the oral mucosa. Got it. So I guess oral mucosa is over here. Pemphigus vulgaris can involve the oral mucosa. Okay, so here you can see that's a beautiful picture. But what is that basically? Okay, there is separation. Acantholysis is depicted here, but I don't think it is acantholysis of the pemphigus vulgaris, because stratum basale is all the way over here, right? Stratum basale is like this, is stratum basale. Okay, so stratum basale and stratum spinosum are separated in between somewhere, so that is acantholysis basically, but you can also take it for the pemphigus vulgaris. And this is the classical picture. The ruptured bullae will look something like that, and this is the oral mucosa. So what else are we supposed to see? I give it a Asbo-Hansen sign. I think you should Google it. You should check this on YouTube. Maybe there's a good sign of that. Moving forward, what is bullous impetigo? So autoimmune destruction of hemidesmosomes. Autoimmune destruction of hemidesmosomes between the basal cell and underlying basement membrane due to IgG antibodies against the basement membrane collagen. Antibodies are below the epidermis. So antibodies which are below the epidermis will cause bullous impetigo. Immunofluorescence highlights IgG along the basement membrane at the epidermal dermal junction. That is, linear pattern of immunofluorescence will be seen. This line of immunofluorescence is present, which is the linear pattern of immunofluorescence, that is also seen in the type 2 hypersensitivity reaction. While in this case, we'll find a fishnet pattern of the immunofluorescence. So in these, both of them are type 2 hypersensitivity reactions. And in type 2 hypersensitivity reaction, what do we find? We find a ribbon-like appearance of the immunofluorescence, ribbon-like appearance of the antibodies which are being deposited on a particular surface. In the case of these things, like in the case of pemphigus vulgaris, that linear pattern, that ribbon-like pattern is in the form of a fishnet appearance, right? And the linear pattern in the case of pemphigus vulgaris is a complete straight line. You have to differentiate it from the lumpy bumpy pattern of immunofluorescence that is seen with the type 3 hypersensitivity reaction. Lumpy bumpy immunofluorescence. So lumpy bumpy immunofluorescence pattern looks something like this. Okay, so where's the lumpy bumpy? You may take this as a picture. So this is lumpy bumpy pattern of immunofluorescence, and this one I guess is type 2 hypersensitivity nephritis. I'm not sure. So lumpy bumpy immunofluorescence is this one, and then what is ribbon like? This is ribbon like. So if they give you a picture of this, there will be a very clear demarcation between the lumpy pumpy and the ribbon like immunofluorescence. Now let's come back to the PDF. So the bullous pemphigoid is going to present as blisters of the skin. Oral mucosa is spared, less severe than the pemphigus vulgaris. Basal layer is detached from the basement membrane, and tense bullae do not rupture easily. That is Nikolsky sign negative. So Nikolsky sign is positive for the pemphigus vulgaris. Nikolsky sign is positive for the pemphigus vulgaris, while the Nikolsky sign is negative for the bullous pemphigoid because these are tense bullae and they are not rupturing easily. You may think of it as more than, so because they are involving more skin layers, the whole epidermis is involved in the covering of this bullous impetigo, so they are more tough and they are more thick, and that is why they are showing a negative Nikolsky sign. So here you can see that this is epidermis above, the dermis is below that, and the bulla is formed between the epidermis and dermis, so they are like tough bullae and they are not going to show the positive Nikolsky sign. Their Nikolsky is negative. Now here we have the differences as narrated by the Uworld. So autoantibody target pemphigus vulgaris. The autoantibody target is desmosome and desmoglein 3 and 1. Histopathology, intraepidermal cleavage, acantholysis, detached keratinocytes, and tombstone cells along the basal layer. Okay, so histopathology will show intraepidermal cleavage, acantholysis, that is detached keratinocytes, and tombstone cells along the basal layer. Immunofluorescence, there will be net-like intracellular IgG, and clinical features include middle-aged or elderly patient, flaccid bullae, oral mucosal involvement, and Nikolsky sign will be positive. So these are the findings we see in the pemphigus vulgaris. And in the case of bullous pemphigoid, we find hemidesmosomes, bullous pemphigoid antigen 1 and 2. Okay, so in this case there were desmosome, desmoglein 3 and 1, and hemidesmosome, bullous pemphigoid antigens 1 and 2. Histopathology, subepidermal cleavage and no acantholysis. Here it was intradermal cleavage with acantholysis and tombstone cells. Immunofluorescence, linear IgG at the basement membrane, while here we found the net-like or the fish net-like pattern of IgG. The clinical features, predominantly elderly, tense bullae, rare oral mucosal involvement, while here we have middle-aged flaccid bullae and Nikolsky sign is positive, Nikolsky sign will be negative over here. Now we'll talk about dermatitis herpetiformis. Dermatitis herpetiformis is not associated with herpes virus at all. It is a misnomer. So autoimmune deposition of IgA at the tips of dermal papillae. At the tips of dermal papillae, we have the deposition of IgA antibodies. So dermal papillae is a structure which is like this is a dermal papilla. This one is the dermal papilla over here. So you may say that this is dermal papilla, the finger-like projection of dermis into the epidermis. These are dermal papilla, this one and this one and this one. So if there is deposition of IgA antibodies in this area, in these areas, so that is called as dermatitis herpetiformis. Present as pruritic vesicle and bullae that are grouped, herpetiform, often found on the elbows. So since they are grouped together, that is why they are called as herpetiform, because they look like herpes vesicles. They are not caused by the herpes virus. Remember that. They are just IgA deposition. So here in this picture you can see subepidermal blister with neutrophil in the dermal papillae in the dermatitis herpetiformis. So this is a blister that is subepidermal, along with the inflammation of the, so this is a blister, and if we see or if we zoom it in, so we'll be able to appreciate the presence of neutrophils. These are the neutrophils which are present inside that. So this is the picture of dermatitis herpetiformis. Strong association with the celiac disease and resolves with a gluten-free diet. So if we are using the gluten-free diet, then the dermatitis herpetiformis will be relieved. Histologically, microabscess containing fibrin and neutrophils at the dermal papillae tips. The overlying basal cells become vacuolated and coalescing blisters form at the tip of the involved papillae. Treatment is with a dapsone and gluten-free diet. Okay, give dapsone and also the gluten-free diet. Then we have erythema multiforme (EM). Presentation: targetoid rash and bullae. So there is targetoid rash and bullae. Looks like target with multiple rings and dusky center, showing the epithelial disruption. If you can see this in the picture. So this is the picture of the erythema multiforme. Erythema multiforme is basically the, okay, so listen, erythema multiforme, when we were doing the microbiology section, so we studied it over there, that erythema multiforme is caused by the coccidioids immitis on the anterior of the shin. That is erythema multiforme. That was erythema nodosum. I'm sorry. Erythema multiforme is not caused by that. Erythema multiforme looks like that. Erythema multiforme. I don't remember what was causing erythema. I guess herpes was causing erythema multiforme. So let's see that. Let's not confuse ourselves. Let's see that. Targetoid rash and bullae looks like target with multiple rings and dusky center showing the epithelial destruction. So these are multiple rings. This one ring and then another ring with a dusky center, and that dusky center is representing the epithelial disruption. Targetoid appearance is due to the central epidermal necrosis surrounded by erythema. May be present with multiple type of lesions, macules, papules, vesicles, and target lesions. Electron microscopy with the oral mucosa, lip involvement, and fever is termed as Stevens-Johnson syndrome. So electron microscopy with the oral mucosa and lip involvement and fever is termed as Stevens-Johnson syndrome. Toxic epidermal necrolysis is a severe form of Stevens-Johnson syndrome characterized by diffuse sloughing of skin resembling a large burn, most often due to an adverse drug reaction. Okay, pathophysiology. Herpes simplex virus infection is causing the erythema multiforme. That is the most common cause. Okay, so these are targeted lesion or target lesions. That's a good one. So these are target lesions, erythema multiforme, and they are caused by the herpes simplex virus. Pathophysiology: hypersensitivity reaction, cell-mediated immune process with an inflammatory infiltrate predominantly by the cytotoxic CD8 lymphocytes associated with the HSV infection, which is most common. Other associations include mycoplasma infection, drugs which are penicillins and sulfonamides, autoimmune disease, for example, systemic lupus erythematosus, and malignancy. Okay, so and malignancy. Moving forward, Stevens-Johnson syndrome. That is a very horrible complication of a lot of things. So Stevens-Johnson syndrome is characterized by fever, bullae formation, and necrosis, sloughing of skin at the dermal epidermal junction, high mortality rate. So at the dermal epidermal junction, there is sloughing of skin over there, and it is very high mortality rate. Typically, two mucous membranes are involved, as you can see. The mucous membrane of eyes and the mucous membrane of the oral cavity is involved. Targetoid lesions may appear as the skin is as seen in the erythema multiforme. So such targetoid lesions may form. These are targetoid lesions, or maybe this one, and you may also see this one. So targetoid lesions may form in the Stevens-Johnson syndrome, usually associated with adverse drug reaction. It is usually associated with the adverse drug reaction. For example, TMP SMX can cause Stevens-Johnson syndrome, or maybe the antiretroviral therapy, that is non-nucleotide reverse transcriptase inhibitors like efavirenz or nevirapine, they may also be associated with the Stevens-Johnson syndrome. A more severe form of Stevens-Johnson syndrome with more than 30% of the total body surface area involved is the toxic epidermal necrolysis, or TEN. So these two conditions are Stevens-Johnson syndrome. That is also dangerous, but it is milder in comparison to the toxic epidermal necrolysis in which more than 30% of involvement is seen. More than 30% of the body involvement is seen. 10 to 30% involvement denotes Stevens-Johnson syndrome, toxic epidermal necrolysis, that is an intermediate of that. So if it is less than 10% involvement, it is Stevens-Johnson syndrome. Between 10 to 30%, it is called as SJS-TEN syndrome, and if it is more than 30% involvement, it is toxic epidermal necrolysis, and it is very, very devastating condition. Miscellaneous skin disorders. Acanthosis nigricans. These are the axilla, and I guess this is below the neck, or maybe below the breast or something, or maybe this is still in the axilla. Epidermal hyperplasia causing symmetric hyperpigmented thickening of the skin, especially in the axilla or neck. Acanthosis. Just give me a second. So acanthosis is over here. Acanthosis means increase in the stratum spinosum. So epidermal hyperplasia specifically in the stratum spinosum, that is called acanthosis nigricans. Coming back to our page. Yep. So we were talking about the acanthosis nigricans. So acanthosis nigricans is epidermal hyperplasia causing the symmetric hyperpigmented thickening of the skin, especially in the axilla or on the neck. So this is in the neck and this is in the axilla. Skin tags, achondrones, are pedunculated outgrowth of the normal skin that are commonly present on the regions affected by the acanthosis nigricans. Due to fibroblast growth factor 23 activating mutations, receptor tyrosine kinase, same as in the seborrheic keratosis. So it is due to the fibroblast growth factor 23 activating mutation, the receptor tyrosine kinase, same as in the seborrheic keratosis. It is associated with the insulin resistance, for example, diabetes, obesity, Cushing syndrome, and visceral malignancy, for example, gastric adenocarcinoma. Now let's talk about actinic keratosis. Pre-malignant lesion caused by sun exposure. Presentation: small, rough, erythematous papules with overlying whitish scales. So these are small, rough, erythematous papules with overlying whitish scales. So these are C and D. So these have overlying whitish scales over here and over here. They are often felt more than seen as okay. So they are often felt more than seen and have a rough sandpaper-like texture on the palpation. Hyperkeratosis is in such lesions may become prominent and form cutaneous horns. So hyperkeratosis in such lesions may become prominent and form the cutaneous horns. Risk of squamous cell carcinoma is proportional to the degree of epithelial dysplasia. So in actinic keratosis, the degree of dysplasia will decide the risk of development of squamous cell carcinoma, and these are the pictures of that. Actinic keratosis. Okay, so there will be a sandpaper-like texture on palpation. Hyperkeratosis in such lesions, hyperkeratosis means excessive production of the stratum corneum. In such lesions may become prominent and form the cutaneous horns, and risk of squamous cell carcinoma is proportional to the degree of epithelial dysplasia. Now we'll talk about erythema nodosum. This is something which I was talking about with the coccidioidomitis and other fungi. So painful raised inflammatory lesions. These are inflammatory lesions of subcutaneous fat. Panniculitis, usually on the anterior shins. That is a delayed type hypersensitivity reaction, type 4 hypersensitivity reaction, often idiopathic but can be associated with sarcoidosis, coccidioidomycosis, histoplasmosis, TB, streptococcal infection, leprosy, and inflammatory bowel disease. So this one is a picture of leprosy. This one is leprosy, and this one is streptococcal infection. But remember one thing: if the person is having AIDS, severe AIDS, and the person is having he is severely immunocompromised, even if he has coccidioidomycosis infection or histoplasmosis or any of such infection, he will not develop erythema nodosum, because that is an inflammatory immune response that is mounted by the hypersensitivity reactions, and the immune system has become so weak that it does not have enough CD4 positive T cells, so the immune response will not be mounted, and resultantly erythema nodosum will not be seen in the immunocompromised patients. Then we have common feature of sarcoidosis, epidemiology, young adults and African American women, basically. Clinical findings, constitutional symptoms. Let me zoom it in. So there will be constitutional symptoms: cough, dyspnea, and chest pain. Extrapulmonary findings: skin lesions, anterior posterior uveitis, and Lofgren syndrome. What's that? Lofgren syndrome. Lofgren syndrome is, I don't have an internet connection, so we'll see that later. So there is a picture of Lofgren syndrome. The Lofgren syndrome is like depicted in this picture. It is a specific acute clinical presentation of systemic sarcoidosis consisting of a classic triad of fever, erythema nodosum, and bilateral hilar lymphadenopathy that is called as Lofgren syndrome. I guess it's a good picture. Lofgren syndrome. There is hilar lymphadenopathy and then erythema nodosum over here, and along with that there will be fever. So these three things together are called as Lofgren syndrome. Coming back to the PDF. So imaging will show bilateral hilar adenopathy and pulmonary reticular infiltrates. Lab values will show hypercalcemia, hypercalciuria, elevated serum acetylcholinesterase levels. Pathology will show biopsy shows non-caseating granulomas that stain negative for the fungi and acid-fast bacilli. So there will be non-caseating granulomas that are the very high yield point, that the granuloma are also formed in the TB and in some other conditions like histoplasma or some other conditions. But the non-caseating type of granuloma are seen specifically in the sarcoidosis that stain negative for fungi and acid-fast bacilli. No, the non-caseating granulomas are found in the sarcoidosis as well as in the fungi. Then will stain for the fungi. If the fungal stain is also negative, then it is sarcoidosis, along with hilar lymphadenopathy and other clinical diagnosis. So the confirmatory diagnosis is done if we find the non-caseating granulomas which stain negative for the fungi as well as for the acid-fast bacilli. Talking about lichen planus, there are a lot of P's, 6 P's for lichen planus: pruritic, purple, polygonal, planar, papules, and plaques. So these are pruritic, purple, polygonal, planar, planar or plantar. I guess it must be plantar. Polygonal, planar, papules. Okay, so lichen planus. Lichen planus must be somewhere over here. Okay, blistering disorders and miscellaneous. Lichen planus. So these are planar papules. Okay. Pruritic, purple, polygonal, planar papules, and plaques. What's planar? So planar papule is okay. Papular form. What's that? Planar papule, polygonal papule. So just forget about it. So it's It is one of the piece that it is going to form. The pruritic purple polygonal planar papules and plaques are 6 pieces of the lichen planus. Mucosal involvement manifests with a Wickham stria, reticular white line and hypergranulosis. It is associated with a sawtooth infiltrates of the lymphocyte and dermal epidermal junction. At the dermal epidermal junction over here, you will find sawtooth infiltrates. Okay, and it is associated with a hepatitis C. Lichen planus is associated with hepatitis C. Let me see Wickham stria. Wickham stria. Wickham stria. So Wickham stria are like these structures. Wickham stria was coined by the Flanflan and correspond to the fine white and grey lines or dots seen on the top of the papular, rash and oral mucosal lesions of the lichen planus. The fine white or grey lines or dots. So these are Wickham stria. These are the stria, like the white lines or maybe white dots, which are seen on the surface of the lichen planus lesion. So they are called as Wickham stria. Coming back to the PDF, they are sawtooth infiltrate of the lymphocytes on the dermal papillae. You can see the sawtooth infiltrates, maybe if you can see them like this over here or maybe over here. No, these are the sawtooth infiltrates. Somehow they look like a sawtooth. This is epidermis and this is the dermis, and at the dermoepidermal junction, at this junction between the dermis and epidermis, we can find the sawtooth lymphocytic infiltrate. Okay, I guess these are the sawtooth lymphocytic infiltrate, although I cannot appreciate them right now, but maybe they're there. Because okay, then we have pityriasis rosea. Pityriasis versicolor was caused by the fungus. Let me see what is causing pityriasis rosea. These are herald patch. So these are herald patches, single round to oval pink patch that is scaly with raised border. Okay, herald patch that is single round to oval pink patch that is scaly with a raised border, followed days later by another scary rhizomatous papule, often called as a Christmas tree distribution on the trunk. Okay, multiple pink plaques with collarette scale and self-resolving in 6 to 8 weeks. So the best part of the pityriasis rosacea is that it is self-resolving in 6 to 8 weeks. It is also called as herald patch. Firstly, a single round to oval pink patch that is scaly with raised border will be emerging. Later on, it is followed days later by other scaly rhizomatous plaques, often as a Christmas tree distribution on the trunk. Multiple pink plaques with collateral scales will be formed. What is sunburn? Here you can see the sunburn. The person would definitely be wearing some vest or maybe a tank top. So he has the distribution of the sunburn in the areas which were exposed. Acute cutaneous inflammatory reaction due to excessive UV irradiation causes DNA mutation, including the apoptosis of keratinocytes. Ultraviolet B is dominant in sunburn. UVA is tanning and photoaging. So for photoaging and tanning and for the treatment of psoriasis, we have UVA, and UVB is for the dominantly seen in the sunburn. Exposure to UVA and UVB increases the risk of skin cancer, can also lead to the impetigo. Then we have pyoderma gangrenosum. This is the picture of pyoderma gangrenosum, non-infectious inflammatory disease that produces painful necrotic ulcers. So pyoderma gangrenosum is going to produce painful necrotic ulcers caused by immune dysregulation associated with the inflammatory diseases, especially the inflammatory bowel disease or rheumatoid arthritis, seronegative spondyloarthropathies, myeloproliferative disease. The big one is that it is non-infectious. Along with that, it is inflammatory disease that produces painful necrotic ulcers. Okay. It presents with a multiple tender red pustules that ulcerate sharply demarcated ulcers with raised violaceous borders and purulent base. Lesions may coalesce into large ulcers 10 cm with a crater hole lesion. Treatment. Treatment of the underlying condition. Treatment contains 3 T's, 1, 2, 3. So that is why they somehow shortened it to form the TTT. TTT underlying treatment of the underlying condition. Superficial lesion with the topical corticosteroids like tacrolimus and cyclosporine. Deep, large lesions with systemic corticosteroid, for example, systemic cyclosporine. Now we'll classify the burns. So burn can be either first degree, second degree, or third degree. First degree burn is superficial through epidermis, for example, common sunburn. That is first degree burn. It is very painful, erythematous, and blanching. If we press the surface, if we press over here, so this will blanch. Okay. Then second degree burn, it is partial thickness burn through epidermis and dermis is also involved. So in this only epidermis is involved, first degree burn. In the second degree burn, the dermis and epidermis, both of them are involved partially. So complete dermis and partial complete epidermis and partial dermis. Skin is blistered. and usually heals without scarring, painful erythematous and also blanching. The third degree burn, in which the whole thickness of the skin has been burnt, full thickness burn through the epidermis, dermis and even hypodermis, that is the subcutaneous tissue. Skin scar without wound healing. So if the wound will be healed, so resultantly there will be the formation of scar, painless, waxy or leathery appearance, and it is non-blanching. Why it is painless? Because the nerve endings have also been destroyed by the burns, and resultantly the painless, waxy or leathery appearance of non-blanching skin is found. So these are painful lesions, the first and second degree burns, while the third degree burns is painless. So epidermis, dermis and hypodermis, partial thickness burns, the first and second degree, and full thickness burn is the third degree. So in the partial thickness burn, first degree burn is damaged epidermis and edema. In second degree burn, we'll have damaged epidermis and dermis. Maybe edema is also present over there, and both of them are blanching. Full thickness, third degree burn, deep tissue damage, no blanching, no pain, and edema may be present. Waxy or leathery appearance will be there. Okay. Now we'll talk about normal wound healing process. We'll also see that in the general pathology section, but let's see it here as well. So the timeline is from up to 3 weeks to several months. So in the first day, from 0 to 1 day, there will be hemostasis, that is stoppage of the blood, stoppage of bleeding, vasoconstriction, platelet aggregation and fibrin deposition. These are the findings which cause the hemostasis in 0 to 1 days. Second step, from 1 to 3 days, is inflammatory. Neutrophil migration. First neutrophils will come and then macrophages will come. Phagocytosis of the necrotic debris and the bacterial contaminants. Proliferative stage, that is from 3 days to 3 weeks. Formation of the granulation tissue. Fibroblasts begin to form the connective tissue. Endothelial cells begin to form the blood vessels, that is neovascularization, and ultimately there will be wound contraction. Maturation or remodeling. From 3 weeks to several months, fibroblasts continue to synthesize the connective tissue matrix, for example the collagen and elastin. Slow progressive increase in the tensile strength of the new tissue. Okay. Okay, we'll see that later on as well. So remember, there are 4 stages: hemostasis, inflammatory, proliferative and maturation. In hemostasis, that is occurring from about 0 to 1 days, and vasoconstriction, platelet aggregation, fibrin deposition will help in that. Inflammatory, neutrophils and macrophages come in 1 to 3 days and they clear off the necrotic debris. In proliferative phase, that is 3 days to 3 weeks, there is fibroblasts begin to form the connective tissue, that is collagen type 3. I guess this is the in the granulation tissue we have type 3 collagen. So type 3 collagen is there in the granulation tissue. Fibroblasts begin to form the connective tissue, and endothelial cells begin to form the blood vessel, that is neovascularization. Along with that, there will be wound contraction because the granulation tissue contains myoepithelial cells as well, which cause the wound contraction. Then maturation is the process that occurs 3 weeks to several months. Fibroblasts continue to synthesize the connective tissue matrix, and that connective tissue matrix is now formed by type 1 collagen. Okay. Slow progressive increase in the tensile strength of the new tissue. Then let's differentiate between the keloid and hypertrophic scar. The keloid, scar overgrowth beyond the wound borders, disorganized collagen fibers and that grow for years. So this is keloid over here. While hypertrophic scar, it is confined to the origin of the wound. Parallel collagen fibers will be seen and regress with time. Hypertrophic scar is going to regress with time. Then let's talk about keloids and hypertrophic scars individually. I guess we are going to talk about keloids only. So keloids, they result from excessive collagen formation during the remodeling phase of the wound. During the remodeling is the last phase. This phase, if there is excessive collagen deposition, collagen formation, that will lead to the excessive wound healing, and that is called as keloid. They present as raised, painful and pruritic nodules that grow beyond the wound borders. Unlike keloids, hypertrophic scars are limited to the wound area and may regress spontaneously, although there is excessive collagen deposition in the hypertrophic scar as well, but that is confined to the borders of the lesion. So if this was a scar, if this was the margin of the wound, so the hypertrophy of the collagen fibers, that is limited inside the border of that. But for the keloid, suppose this was suppose we are supposing that this was the initial lesion and the keloid has grown all the way over here. That is most commonly seen in the ear lobules after piercing of the ears. Then we have keloids can have family tendency, particularly in a person of Asian or African ethnicity. Histology consists of the connective tissue rich in fibroblast, myofibroblast and bundle of collagen fibers that are arranged in a disorganizing fashion in keloid and in parallel in hypertrophic scar. So the bundles of collagen fibers will look like this in the case of keloid, in the case of hypertrophic scar, and something like this in the case of a keloid. Okay, something like this. Yep. So this is keloid and this one is hypertrophic scar. Then pathophysiology, transformation growth factor beta, TGF beta promotes the differentiation of the fibroblast into myofibroblast and should diminish on completion of the wound repair. In keloids, the transforming growth factor beta is produced excessively without regulation. As a result, keloids extend beyond the borders of the original wound, do not regress, and often recur after resection. They recur after resection. Now let's talk about skin cancer. First, we will talk about the basal cell carcinoma. Most common skin cancer, locally invasive but rarely metastasizes. Risk factors include ultraviolet B induced DNA damage and include prolonged exposure to sunlight, albinism, and xeroderma pigmentosum, immunosuppressive therapy, and arsenic exposure. Okay, basal cell carcinoma is associated with immunosuppressive therapy and basal cell carcinoma or BCC. It is associated with a prolonged ultraviolet B exposure, immunosuppressive therapy, and the arsenic exposure. Presentation: nodular and ulcerative lesion, waxy pink, pearly nodules, commonly with the telangiectasias, and rolled borders, central crusting or ulceration. So rolled borders, the rolled in borders, I guess they are characteristic of the basal cell carcinoma. This is a picture, I guess, of the rolled borders, or maybe this one. Okay, so there will be rolled borders, central crusting or ulceration. The rodent ulcer, non-healing ulcers with the infiltration with infiltrating growth. So non-healing ulcers with infiltrating ulcer. I guess this one is a rodent ulcer. So what is in the rodent ulcer? The non-healing ulcer with infiltrating growth, or as a scaling plaque, that is superficial basal cell carcinoma. Histology: basal cell tumors have palisading nuclei. So basal cell tumors will have palisading nuclei. This one maybe. These are palisading nuclei, like the nuclei are palisading this area of necrosis or maybe the area of inflammation. So they have palisading nuclei which are forming a border. Like here you can see the palisading area. This one. So all the zone between that, like this zone, that is a palisading zone. Then let's talk about the difference between the basal cell carcinoma and squamous cell carcinoma. The basal cell carcinoma does not have precancerous precursor. They are related to the intermittent sun exposure, do not metastasize but could be invasive. HPV can cause basal cell carcinoma and less association with the scar and chronic ulcer. In the case of squamous cell carcinoma, it has a precancerous skin lesion, for example, actinic keratosis, for example, related to chronic accumulative sun exposure. Then it can metastasize to the lymph nodes and to the internal organs and cause death. HPV can cause squamous cell carcinoma as well. HPV can't cause basal cell carcinoma. Remember this. HPV cannot cause basal cell carcinoma, but it can cause squamous cell carcinoma. The squamous cell carcinoma has more association with scar and chronic ulcer. Let's come back to the squamous cell carcinoma. Second most common skin cancer. Risk factor is excessive exposure to the sunlight. For the basal cell carcinoma, the intermittent sunlight exposure will cause basal cell carcinoma, but the excessive exposure to sunlight is going to cause squamous cell carcinoma. Immunosuppression, chronically draining sinuses, and occasionally arsenic exposure can also cause squamous cell carcinoma. Arsenic exposure was also leading to basal cell carcinoma. Here you can see that ultraviolet B, immunosuppressive therapy, and arsenic exposure is also associated with the basal cell carcinoma. Actinic keratosis, or the precancerous lesion, is the precancerous lesion for squamous cell carcinoma. Presentation: commonly appears on face, lower lip, and ears and hands. So it is on the face over here. I guess it's the nose bridge. Yeah, this is the lower lip, and also on the ears and hands. Ulcerative red lesions with frequent scales, hyperkeratosis. Histopathology: there will be keratin pearls. As you can see in this picture, there is not a very good picture of keratin pearls, but the keratin pearls are present, because keratin pearls are present in any kind of squamous cell carcinoma, be it in the tongue, be it on the tongue or the uvula or oral mucosa of the esophagus, of the skin. Anywhere squamous cell carcinoma is present, the histology will show the keratin pearls. They are locally invasive and may spread to the lymph nodes and will rarely metastasize. Actinic keratosis, scaly plaque, precancerous to the squamous cell carcinoma. Keratocanthoma, well differentiated squamous cell carcinoma that develops rapidly and regresses spontaneously. This is the keratocanthoma. Presents with a cup-shaped tumor filled with keratin debris. So this is cup-shaped tumor that is filled with a keratin debris that regresses spontaneously. Keratocanthoma will regress spontaneously. Then here is the difference between the basal cell carcinoma and the squamous cell carcinoma. So basal cell carcinoma both usually occur on the sun exposed areas. Most common type of skin cancer is the basal cell carcinoma. Shiny pearly papule or nodule. Shiny pearly papule or nodule will be present. umbilicated center and the telangiectasia. So umbilicated center, as you can see here, there is an umbilicus on the tip of the nose. So umbilicated centers and telangiectasia, as you can see in this picture. So these are the characteristic findings of the basal cell carcinoma, and they also grow slowly. In the case of squamous cell carcinoma, more common in the immunosuppressed or transplant patients. Then hyperkeratotic lesions with a crusting and ulceration. Their hyperkeratotic lesion with a crusting and ulceration can be more aggressive than basal cell carcinoma. Okay, and they are more common in the immunosuppressed or the transplant patients. So this is a basal cell carcinoma with telangiectasia, and umbilicated center is not seen, but the basal cell, but the telangiectasia are evident. In the case of squamous cell carcinoma, here you can see maybe a non-healing ulcer. What is melanoma? So melanoma, malignant neoplasm of the melanocytes, most common cause of death from the skin cancer. Common tumor with significant risk of metastases. Depth of the tumor, Breslow thickness correlate with the risk of metastases. The most common metastatic tumor of the brain are lung cancer, renal cancer, and the melanoma. Pathogenesis, often driven by activating mutation of the BRAF kinase. BRAF is a protein kinase involved in activating the signaling pathway of the melanocyte proliferation. BRAF mutation V600E, that is valine to glutamic acid. Okay, so valine is replaced by glutamic acid at position 600, something like that. V600E mutation in the BRAF. Vemurafenib, a potent inhibitor of the mutated BRAF, has significant anti-tumor effects with improved survival and long-term outcomes in advanced stage V600E positive melanoma patients. The presence of BRAF mutation in this patient tissue samples. The presence of okay, so this is a discussion of the Uworld, so that is why there would be some question, and the question had BRAF mutation in the patient's tissue sample most likely indicate the diagnosis of metastatic melanoma. So forget about this line. These are normal melanocytes, and then we have melanoma. So normal melanocytes, we have NRAS activation by the serum growth factors that lead to BRAF activation, that lead to activation of the nuclear DNA replication, cellular growth, differentiation, and survival. In the case of melanoma, the mutated BRAF gene will lead to NRAS independent and uncontrolled BRAF activation. This BRAF activation was controlled by NRAS, but here it is an NRAS independent BRAF activation. Resultantly, we have very high activation of nuclear DNA replication, increased cellular growth, increased differentiation, and increased survival, and that result in metastases. Risk factor, sunlight exposure, dysplastic nevi, and fair-skinned person. Characterized by two growth phases. The first one is radial growth and the second one is vertical growth. Radial growth, horizontally along the epidermis and superficial dermis, low risk of the metastasis. Vertical growth into the deep dermis, increased risk of metastasis. Depth of extension, that is Breslow thickness, is most important prognostic factor in predicting the metastasis. Okay, so Breslow thickness in the case of a melanoma is the most important factor, prognostic factor for predicting the metastasis. Clinical picture of melanoma are ABCDE. So A is asymmetry. When bisected, the two sides are not identical. Okay, we saw that in somewhere back. I don't remember where, but I guess in the Uworld session we saw that. Then B is the border irregularities, uneven edges, pigment layering of color variations, variable mixture of brown, tan, and black and red. Diameter is more than 6 millimeters. Evolving lesion changing in size, shape, or color, and new lesion types: superficial spreading, nodular, lentigo maligna, and acral lentiginous. Blah blah blah. So first one is superficial spreading. Most common subtype, dominant early radial growth, result in good prognosis. Okay, dominant early radial growth. Suppose that this is the skin finding and the melanoma has developed there. So if it is spreading laterally or radially, that is a good prognostic factor. If it has started going deep or vertically, that has a bad prognostic value. So the superficial spreading one has early radial growth, and that is why it has a good prognostic value, because it is detected early on. So this one as depicted over here, this is the superficial spreading. Then we have nodular type, early vertical growth of melanocyte, elevate the epidermis that form the nodule, and that is a poor prognosis because it has early vertical growth. This is a nodular type, and it has a poor prognosis because it spreads very early onto the dermis and to the subcutaneous tissue, and then it can metastasize. Lentigo maligna, lentiginous, remain in the dermoepidermal junction, that is radial growth and has good prognosis. So this thing, the lentiginous, that is it is in the dermoepidermal junction. It has a radial growth and good prognosis. Acral lentiginous. What is the meaning of acral lentiginous? Arises on the palms and soles. Highest prevalence in the African Americans and Asian dark-skinned individuals. It is not related to the UV light exposure. Acral lentiginous, it is not related to the UV light exposure. So remember these things, that we have superficial spreading, nodular, lentigo maligna, and acral lentiginous. This one is acral lentigina, that is present on palms and soles. Okay, highest prevalence in African Americans and Asians, dark-skinned individuals, and it is not related to the UV light exposure. Diagnosis: S100 tumor marker and BRAF mutations. Treatment is excision with appropriately wide margins because we don't want to leave any part of the melanoma on the skin. Metastatic or unresectable tumor in the patient with a BRAF V600E mutation may benefit from vemurafenib, a BRAF kinase inhibitor. So here is a picture of the malignancy potential or prognostic values of the melanoma. So the grade 1 is the one in which what? So these are Breslow suggested measuring from the tip of the granular layer to the bottom of the melanoma using an ocular micrometer within the microscope. This method is highly reproducible and now widely used. So if it is present in the epidermis only, like if it is present only in the epidermis, the upper layer is epidermis. So if it is present only in the upper epidermis, it is grade 1, right? It is a Breslow's 1 or Clark level 1. If it is present in the number 2 is dermis. So if it is present as a dermis only, dermis and epidermis, so it is stage 2. If it has invaded dermis, epidermis and reticular dermis, okay, so then it is stage 3 or maybe 4. If it has gone even beyond that, so it is stage 5. Okay, I don't know. So stratum granulosum, papillary dermis, then reticular dermis, and subcutaneous fat. So in the layer 1, you can see it is present only in the epidermis. Then layer in the stage 2, it has started entering the papillary dermis. Then it has completely entered the papillary dermis. Then it starts entering the reticular dermis in the stage 4. And in stage 5, it has reached all the thickness of the skin and now has reached this layer, that is the subcutaneous fat. So these are some findings like this one and of this one. Here is another one. There is a melanoma. Now we'll talk about topics on the Uworld. Firstly, now we're done with the musculoskeletal, and now there are accessory topics on the Uworld, and after that we'll go to the pharmacology. So accessory topics on the Uworld: accessory nipples, polythelia, supernumerary nipple. What is meant by that? The most common congenital breast anomaly in the women and men, resulting from failed regression of the mammary ridge in utero, usually asymptomatic. However, they may swell and become tender, similar to the normal breast tissue before or during the menses, pregnancy, and lactation. Findings include hyperpigmentation, epidermal thickening, pilosebaceous structure of the Montgomery areolar tubercles, smooth muscle bundles areola, and possible mammary glands and multiple nipples. So along the mammary ridge, here you can see that is starting from the axilla going all the way to the groin. So these are the positions where the supernumerary nipples can possibly be present. Position of the accessory nipples. Then we'll talk about androgenic alopecia. So these are some stages like stage 1, 2, and 3. So hair loss primarily at the anterior scalp and the vertex. So at the anterior scalp, this is anterior scalp, this one, and this is the vertex. So if the hair loss is in these regions, anterior scalp and vertex, shows polygenic inheritance. So they show polygenic inheritance with the dihydrotestosterone being primary pathogenic factor. 5-alpha reductase inhibitor finasteride decreases the conversion of testosterone to dihydrotestosterone and are effective for treating this condition. Vitamin A can be beneficial in the treatment of measles infection by reducing the comorbidities, for example, the ocular complications, diarrhea, and pneumonia. Recovery time and length of the hospital stay can also be, recovery time can be prolonged, recovery time and hospital stay can be decreased. Drugs for the neuropathic pain, these are some drugs which we use for the neuropathic pain. Now these are individual points as we see at the end of all the systems. So tricyclic antidepressants and amitriptyline and nortriptyline decrease the reuptake of serotonin and norepinephrine, inhibition of pain signals. Anticonvulsant, for example, the gabapentin and pregabalin, decreased depolarization of neurons in the CNS. Opioids, activation of cellular opioid receptors. Capsaicin, topical, loss of membrane potential in the nociceptive fibers. And lidocaine, topical, decreased depolarization of neurons in the peripheral nerves. Topical application of capsaicin causes release of substance P in afferent pain fibers, resulting in the burning or stinging sensation. However, chronic application leads to the depletion of substance P and reduced pain transmission. It is used in the neuropathic pain syndrome such as post-herpetic neuralgia. Then we'll start pharmacology in the next session. So thanks for sticking this long, and just hold tight, and now we are going to finish this musculoskeletal system soon, maybe in the next session or maybe in the next two sessions. I will try to complete it in the next session, but let's see. because there are extra points as well. Yeah, because we have to do 1491 and right now we are 15. Yeah, there's some 15 to 16 pages which are left, so I will try to complete them in the next session. Until then, Allah Hafiz, Fi Manila, and